disorders neurologist at UT Southwestern. And I recognize some of these faces out here, so thank you guys all for joining. Today I'm going to spend a little bit of time talking about mood disorders and Parkinson's disease. It's often an overlooked topic, so I hope we can learn a few new things today. There we go. So oftentimes when we talk about Parkinson's disease, people generally think of just the motor symptoms or movement symptoms. So typically your tremor, the slowness of movements, stiffness, balance issues, but there are several non-motor symptoms that also greatly impact those with Parkinson's disease. And like I said, today we're going to spend time talking mostly about mood and behavior changes. So I like to show this picture. This is an iceberg, and I think it kind of makes that point that I just spent last slide on. So when you look at an iceberg, you see something like this, and I like to kind of use this as an analogy or a metaphor for the motor symptoms of Parkinson's. You see the tremors, you see the slowness of movement or bradykinesia, but there is a large part of the iceberg that's there below the water surface that oftentimes doesn't get fully recognized or discussed. And these are often the non-motor symptoms. And this is not a complete list. This is just a very small list of the non-motor symptoms of Parkinson's disease. So I think it's helpful to be aware of what the non-motor symptoms are so that you can discuss it with your doctor, because oftentimes people write it off as being completely unrelated when in fact it is related to the Parkinson's disease itself. So as I have listed here, it's often under-recognized, and it negatively impacts the quality of life in up to 84% of those with Parkinson's disease. So what is the cause of these mood changes? So yes, it can be a result of just receiving the diagnosis of Parkinson's. There is a period of time where you're taken back, you're surprised, you're shocked by the diagnosis itself, but most commonly, what people fail to realize is that there are changes in the brain chemistry that goes on with Parkinson's disease and is the actual root cause of sustained mood changes. So, as many of us know, when you have loss of dopamine, that is what causes the Parkinsonisms. But the same pathway that creates dopamine also creates a neurochemical called serotonin. And serotonin is very important in regulating mood, appetite, and sleep. So approximately 50% of people with Parkinson's disease will experience mood changes at some time in their course. So here you can take a look at this picture, and on the left, I've listed out just a couple symptoms. There's many, many symptoms, but a couple symptoms that you can see with a loss of dopamine. So when you have less dopamine in your brain, you have Parkinson-like symptoms, the movement-type symptoms, slowness of movement, stiffness, and dopamine is responsible for the pleasure pathway. So loss of dopamine itself can lead you to feel like you have less of a reward or less pleasure in things that you have normally used to enjoy. Serotonin, when you have a loss of serotonin, you can have OCD-like symptoms, obsessive thoughts, compulsive behaviors, and impulsivity. When you have, and like I said, the pathway that's responsible for one is also responsible for the other. And so oftentimes, especially in Parkinson's, you have the combined effect. And that's where you get a lot of the mood changes. So you have less serotonin, less dopamine, causes a lot of depression, a lot of anxiety, and we're going to go over that. And it also affects sleep and your appetite as well. So taking a look at this graph, you can see that along the x-axis, so along the bottom, is time in years. And right there at this center is time 0. So that's usually when the diagnosis is made, okay? And so the diagnosis, you can see the symptoms right around there, and I don't think, oh, it is a pointer, so I'm gonna see if I can get it on here. Probably not, okay? Not at the right angle for it, but you can see that it's those movement symptoms, the motor symptoms, tremor, that's usually what is used to get a diagnosis, to make a diagnosis clinically of Parkinson's disease. But if you direct your eyes just before that time 0 point, so somewhere in that 5, even up to 5 years before, you see that there's depression, okay? There's, loss of smell, depression. Even before that, REM sleep behavior disorder, which you may have heard of, with the dream enactment symptoms. And not everyone will experience all of these, but these are early, what we call prodromal symptoms that do present themselves before the movement symptoms, oftentimes. And then later on in the disease course, you can see, 10 to 20 years, you can even have in that darker blue area, psychosis that can present itself. And we'll talk about that later. So here's the depression just prior to that 0 mark. So when do they occur? Like I just showed you, it can occur before the onset of the movement symptoms. It can be noticed years after the diagnosis of Parkinson's, and we're going to spend a little bit of time in the next slide talking about the mood, particularly the anxiety that occurs suddenly in the wearing off state. So as your medicine is wearing off and wearing out of your system, sometimes my patients have described that they get this severe feeling of anxiety and restlessness that can occur. So this is a little picture that kind of shows you what motor fluctuations are. So taking a look, you can see, so each one of these little swoops that you're seeing is the level of dopamine or carbidopa-levodopa, cinnamate, Rytari, level of the Parkinson's medication in your bloodstream. And as it increases into that white range, that's where I like to call the sweet spot. That's where you're feeling really good, your medicine's working well, you're moving well. And in the beginning with Parkinson's disease, it's really easy to kind of keep you in that white area, that sweet spot area. But as the disease progresses, and I'm sorry that this pointer, I can't get it to work very well for you guys, but as the disease progresses, you can kind of see how that sweet spot starts to narrow over time. And now that medication that you've been so used to taking takes longer to kick in. That's that dark blue area, so it takes longer for it to finally get into your bloodstream at a level that's going to make you feel really good and move easily. And we often now start overshooting that sweet spot, and you have what we call dyskinesia, that's where you have too much movement. But in that process of wearing off, so when you get back into that blue region, that's where you have the severe anxiety that can kick in. And so whenever my patients tell me, every once in a while throughout the day, I'll get really severe anxiety, I always ask them, okay, what time of day is that? And what time is that in relation to your medication? Because that's a very easy fix. We just have to change the timing of your dose and prevent that early wearing off, and then we can prevent the anxiety. But when you have more sustained anxiety that's not related to the medication timing, that's when we need to start thinking about longer-term treatment options for the anxiety itself, and we'll talk about that. Okay, so common symptoms when it comes to mood changes in Parkinson's are depression, so feelings of sadness, hopelessness, emptiness, anxiety, feelings of nervousness, worry, tension, unease, restlessness, and oftentimes panic attacks that can result from that when it gets severe. And then apathy. Apathy is one mood symptom that I feel is often overlooked, even more so than the others. So apathy is when you have a lack of interest, enthusiasm, no motivation to get things going, get things started up. And apathy is usually a significant factor that leads people to self-isolate, which then worsens the depression and anxiety, and it's just a terrible cycle. So these symptoms can present themselves one at a time, or they can often commonly coexist with one another. So it's important to recognize them. So again, under-recognized, these are underdiagnosed and unfortunately undertreated. So let's go one by one. Depression. It has been reported in up to 50% of those with Parkinson's disease. It's very, very common. The impact of depression can also extend to your family members and can be a cause of care partner or caregiver burden. It's just as important, if not more important sometimes, to treat than the movement symptoms. The movement symptoms, you know, that's why I try to make it a routine question, especially when I'm first meeting with my patients. What's bothering you the most? We just spent all this time talking about the movement symptoms, the memory problems, the mood problems. Of all these things, what can I focus on first for you? Because everybody's journey with Parkinson's is very different. And so, you know, if I'm seeing a little bit of a tremor in someone and I'm just aggressively trying to go after the tremor and just focus my treatment on tremor, that may not be what that person finds bothersome. Maybe it doesn't bother them at all. And maybe it's the looming feeling of sadness that they have every single day. It's caused them to not get out of the house. They've lost their friends. They've, you know, lost enjoyment in doing what they used to do. So it's really important to be able to bring that up to your physician, let them know, hey, I really want this visit to focus on X, Y, and Z. So untreated depression can be very disabling and very deadly if it just keeps going on and leads to a point in which someone starts to think about suicide, unfortunately. So recognizing depression. So this is from the DSM-5 diagnostic criteria. So these are questions that you can ask yourself or your loved one to kind of screen for major clinical depression, meaning not just mild symptoms of sadness, but in general, do they have depression to a point in which needs actual prescription treatment? And so if you don't have to fulfill all of these, but if you have more than 4 of these, if you say yes to more than 4 of these, then that in itself, sorry, let me back up a little bit. So if you say yes to more than 4 of these questions, and you've been feeling this way most days for at least 2 weeks in time, that in itself gives you a diagnosis of major clinical depression and needs to be treated. So I'll just quickly kind of read through these. Do you constantly feel tearful, empty, or worthless? Do you have little interest or pleasure in activities you previously enjoyed? Do you notice dramatic changes up or down in your appetite or your weight not related to dieting? Do you often feel listless or fatigued for no obvious reason? Do you have trouble concentrating or making decisions? Do you find yourself wringing your hands, pacing, or showing other signs of anxious restlessness, or the opposite, which is moving or speaking more slowly than usual? Obviously, there's a little overlap with what Parkinson's movement symptoms can do. So we kind of have to take everything in the right context. But another one, do you struggle with insomnia, or do you sleep too much? Do you have recurrent thoughts of suicide or death? So again, more than 4 of these symptoms for at least 2 weeks at a time, it does give you a diagnosis of major depression. So anxiety. And I'm sorry, I think my slides are cut off just a little bit, but this anxiety symptom can present up to 40% of Parkinson's patients. Very, very, very common. So you have symptoms like loss of confidence, fear of social situations, and public speaking. Feelings of nervousness, worry, tension, unease, and restlessness. You can have a generalized anxiety state where you just have an uncontrollable sense of worry. We talked a little bit already about the motor fluctuations, and as the medication wears off or is in the on state, overshooting it, you can have a feeling of anxiety, and that's just all medication related with, you know, a different treatment plan there. Panic attacks are very common. I hear about them all the time. So sweating, heart racing, difficulty breathing, your tremors get much worse all of a sudden, and you get that feeling, maybe butterflies in the stomach. So anxiety and depression, both of which, maybe even more so than anxiety, can make your symptoms look, your motor symptoms, your movement symptoms appear much worse transiently because you're just in that state of anxiety at the time. So your tremors get worse, it kind of exacerbates your slowness as well. And so oftentimes treating the anxiety will then, you know, indirectly treat the movement side of things as well. So some tips to deal with anxiety: eating a healthy, balanced diet, Sleep for 6 to 8 hours regularly every night. Use deep breathing exercises, exercise regularly, laugh, spend time with family, friends. And I really like this, create a daily routine. So we as humans are prone to feeling much more comfortable, much more in control of our lives when we have a routine set. And creating that routine kind of helps you know what to expect for the day, not have tons of surprises show up that then will trigger anxiety. So creating a routine, I think, is very important. So treatment, so medication related on and off, wearing on and off symptoms, we just make adjustments to the Parkinson's meds. Psychotherapy is very helpful. For generalized anxiety, we use antidepressants, which I'm going to spend a little time talking about in a few slides. And we even have anti-anxiety agents that we use for more severe panic attack type episodes. Apathy. So apathy is, as I mentioned before, a lack of motivation. You have diminished goal-oriented behavior. It can negatively impact the quality of life, contributes also to caregiver burden, and there's just an overall lack of initiative. People with apathy will be described as, it just seems like they don't care. They have emotional indifference. They have reduced affection for others, and there's a lack of concern for others' feelings. And this is, again, reminder, part of the disease. So apathy has been very difficult to treat, oftentimes because it's very difficult to recognize. And it can cause a lot of, as you know, caregiver burden, relationship burden, marriage burden, and so if it's not recognized, talked about, you may not realize that that's part of your Parkinson's disease. It's not necessarily something that just organically came about because your relationship is going through struggles in that way. So it's important to try to speak to your physician about these symptoms that have come up. Treatment of apathy may result in improvement of the quality of life of the patient and those around them. And there have been several randomized clinical trials that show that your medication, Parkinson's medication, the carbidopa-levodopa, actually does help with apathy, as well as a class called cholinesterase inhibitors. So that's your rivastigmine/Exelon, donepezil/Aricept, which help improve apathy. So pausing here to just give you guys a reminder. Mood changes are a non-motor symptom of Parkinson's, and it's not a sign of weakness. So I'm just going to have you look at that for a good minute, maybe less, while I take a sip of water, because I think that's super important to emphasize. Okay. So what do we do? You should speak with your doctor. You should have a comfortable relationship with your physician and be able to talk openly about all of your Parkinson's symptoms, both the movement and the non-movement related symptoms. Movement disorders neurologists are very familiar with these symptoms, so make sure that you bring it up to them. Even though I'm quote-unquote a movement disorders neurologist, I'm also treating the non-movement things, right? And so oftentimes I'm kind of like a primary care doctor when it comes to Parkinson's disease, because that's oftentimes the main disease that someone's facing day to day. And so I help manage, I find myself more and more managing the psychiatric side, the mental health side of things. And I work closely with our psychiatrists if it becomes more and more complex and certain medications aren't really doing what I would expect them to do. And as the disease progresses, it can become a much more complicated picture. But for the most part, movement disorders neurologists should be able to handle, in general neurologists should be able to handle depression, anxiety. We're all trained and board certified in both psychiatry and neurology. So make sure that you bring that up. Build a strong support system. So your loved ones and others around you with Parkinson's disease are a really great community to keep with you. And so reach out to them when you need help or encouragement, And they might be the ones that notice the change in you before you yourself have picked up on it. If you feel depressed, make sure that you talk to someone. And if you feel like, it's too difficult to do that, and some people have a lot of difficulty being very open about those things, there are several online chat forums that I'm going to give you guys access to, or I'll give you guys a list of, that you can maybe take a picture, or I'm not sure if you guys get my slides in general, but there are several resources out there. And then for family and caregivers, if you're concerned that your loved one may be depressed, just try to gently bring up the subject. Maybe say something like, you don't seem like yourself lately, how's your mood? I have heard from a lot of family members that they are somewhat reluctant or afraid to even bring it up to their loved ones because they feel that maybe bringing it up will put attention on the problem and make things worse. But there have actually been studies out there that showed that when you talk about feelings of depression or suicidal thoughts, it doesn't increase or worsen them, but it actually brings about a sense of relief. So it's really important that we do discuss them when we see it. And here's just a general list of some supportive lifestyle changes that have worked for many of our patients and have been studied as well in clinical trials. So therapy, always helpful no matter what you're facing. Making art, journaling, exercise, practicing mindfulness, meditating, massage. Acupuncture actually has some supportive research studies showing its benefit for anxiety in particular. Staying socially active, join support groups, talk with someone. And there's many things you can do. But just trying different things that you haven't tried before, I think is very helpful. So let's go on to talk a little bit about the medication side. So antidepressants, these regulate mood and related chemicals like serotonin, norepinephrine, and dopamine, and they can affect how the neurons in your brain communicate with one another. And so a really important point that I like to remind people of is that it's not an instantaneous change. This can take up to 6, even 8 weeks for it to fully build up in your system to where you're actually noticing some level of benefit. And oftentimes your physician's going to start at the lowest dose. So you might even just notice just a little bit of benefit, and then the dose still needs to be adjusted from there. And that's just safety-wise, making sure that you can tolerate the medication well. I personally do like to start on the lower end of the dosing scale. So don't give up on it. Don't quit your medicine because you feel like it hasn't helped. Stick with it and discuss with your doctor what you're noticing. And if maybe that's nothing. And so certain things need to change and adjustments need to happen. Antidepressants are used to treat both depression and anxiety. So a little bit of a misnomer calling it an antidepressant, but it does treat both of those symptoms. So the main class that we use is a class called SSRIs, or selective serotonin reuptake inhibitors. These are just a few of the many, and there's several drugs within that class, but Zoloft, Prozac, Celexa, these are just a few of them. Serotonin and norepinephrine reuptake inhibitors, as you can tell, work on both of those neurotransmitters. Cymbalta, Pristiq, effects are examples of those. Norepinephrine and dopamine reuptake inhibitor, like bupropion, is also very beneficial. And everyone's different. Some people respond really well to one medication and they notice no benefit with another. So sometimes you have to try different medications, even within the same class, and your doctor should be able to help you with that. And sometimes a combination is what ends up working. For severe anxiety episodes, medications within the benzodiazepine drug group can be used, like Xanax, clonazepam, Ativan, lorazepam. All of those groups of medications can be helpful. They're called anxiolytics. It breaks the anxiety. But I'm very cautious with its use. Oftentimes when I see patients on it, I ask them, how long have you been on this medicine? And if it's been, several months, several years, I tend to want to wean them down and off, and then instead put a longer acting medicine, because because this is a very short-acting medication and is often used to kind of bridge you over in that 6 to 8 week time period where, before we actually notice the effect of the long-acting antidepressant. And the reason I do that is because in patients over the age of 65, there is a black box warning on these drugs that it can increase the risk of falls, and falls, as you guys all know, that is a part of Parkinson's disease, so I want to be cautious of that. And with prolonged use, it actually causes memory loss, which a lot of people don't realize. So it's also important for me to have that discussion with them and with their provider, whoever's prescribing it. So I'm very cautious with those medications, but sometimes it's the only thing that works in those severe anxiety episodes, and so we use it judiciously there. So in summary, there are different ways to treat your mood symptoms. Antidepressants, anxiolytic medications can treat depression and anxiety. Dopamine drugs that improve movement symptoms can also sometimes help improve your depression and anxiety, especially if those mood changes occur in those fluctuations, in the wearing off or in the overshooting dyskinesia type state, the peak of the medication effect. Psychotherapy can help with depression and anxiety. Getting more sleep, social support, and avoiding stress may also help. Now, I want to move on to talk a little bit more about pseudovulvar affect, because I find that many patients have never heard about this. And it's fairly common. It has been reported up to 24% of patients with Parkinson's. So it's these episodes of time where someone is experiencing uncontrollable outbursts of crying or laughing. Usually crying is, I think, much more common. So one patient gave me an example of, she's watching TV and then an animal rescue commercial came on. And we can all probably, nod our heads and realize, okay, it's a sad commercial, okay? But how many of you, you can raise your hands, how many of you would start to uncontrollably cry when you see it? So none, okay? So for her, she uncontrollably cried. Like as soon as she sees it, it became a trigger. She was crying for maybe, she said, 5 to 7 minutes before she could finally stop. She herself knew that this was odd. She could say through her tears, I do not know why I'm still crying. She had trouble controlling it. That's what pseudovulvar affect is. It's the out of proportion response to the trigger. So these outbursts can occur very frequently, and it can be very unpredictable. So you can see how that can really be something that negatively impacts somebody's quality of life if they're out with friends and something's mentioned that's a small trigger, and then something like that happens. So it's often mistaken for depression or even bipolar disorder because of this extreme change in mood. And in between these episodes, the mood's back to normal. So it's really these episodic events. And so in the brain, it's a problem of what we call the prefrontal cortex of the brain. And it's often seen in lots of neurodegenerative conditions, Parkinson's just being one of those. So Nuedexta is actually the only FDA-approved medication that is targeted to treat this problem. So if that sounds familiar to any of you guys, make sure that you speak with your doctor about it. Let's move on to talk about Parkinson's psychosis. So there's a pretty high prevalence of this occurring in about 20 to 40% of people with Parkinson's disease. They can experience hallucinations, much more common than the delusions, which also can occur. And typically we do see this as the disease progresses in the later stages, but it can occur at any point in time if it's related to your medication dose. Maybe there's certain adjustments that need to be made. And so hallucinations, we'll go into more specific details in the next slide, but seeing, hearing, or feeling something that's not actually there. Delusions are illogical, irrational, dysfunctional views, or persistent thoughts that are not based in reality. It's important to recognize this is not deliberate. This is very real to the person that's experiencing them, and it does end up causing a lot of behavioral changes. So risk factors for the psychosis is if there's underlying dementia, if there is underlying uncontrolled severe depression, Sleep disorders, older age, and then advanced or late-stage Parkinson's. All of these things can be risk factors for the psychosis itself. So let's focus on hallucinations first. So visual hallucinations are the most common form of hallucinations that we do see in Parkinson's disease. So oftentimes our patients will say that they are seeing certain animals or people that are either familiar or unfamiliar to them. Usually these are non-frightening hallucinations. So they see somebody in the room, it doesn't frighten them. Oftentimes they have pretty good insight. They know that it's not really there. And then sometimes it starts up with just seeing a shadow out in your periphery. That's what I would call a poorly formed hallucination. So auditory hallucinations are hearing voices or sounds that are not real, and others will describe like a feeling or a presence in the room. And so this can be a side effect of medication. It's more likely to occur in people who have underlying memory problems at baseline, whether it's earlier or late stage of Parkinson's. That's regardless of that. Or when people are under severe medical, physical stressors, oftentimes, let's say in the hospital, you're there with pneumonia, you're at increased risk of delirium, which then in itself causes a kind of reversible episode of hallucinations or psychosis. Moving on to delusions. So there's several examples I've listed here and how they affect the behavior. So one belief, these are the more common ones I hear about, so your partner is being unfaithful, okay? This is a very common delusion. Delusions in themselves are not as common as hallucinations, but when we have them, this is one that I commonly hear about. And it causes the person to have a change to their behavior. So they become more paranoid, more agitated, they become very suspicious of their loved one, and they can start having some aggressive behaviors. Another one that I hear about, that the patient's been attacked, harassed, cheated, or conspired against. And again, that can lead to paranoia, suspiciousness, all those kind of similar behaviors. Another one I've heard about, so your body functions in an abnormal manner. You develop an unusual obsession with your body or your health, and it leads to behavior changes of anxiety, agitation, several or more frequent doctor visits regarding certain symptoms that just don't fully, there's no basis for those feelings that your body is starting to shut down or act in a way that's unusual. So causes. So medications is often a big cause. So that's always when I hear about hallucinations or any psychosis, I look at the medication list. Pain medications, often a big cause. Those anxiety medications can sometimes be a cause that I mentioned before, the ones that I use very cautiously. There's a whole slew of medications that can cause this. Sometimes even some of the Parkinson's medications that were helpful for certain symptoms, like Tranzadome, which we use often for dyskinesias, the irregular, too much movement state when you're swaying and rocking and kicking irregularly. That is a really great medication for dyskinesias, but if I see a history of hallucinations or psychosis, I wean them off of that right away, because that in itself can reverse the hallucination problem. Sometimes if your dose of your carbidopa-levodopa is too high, that can also trigger some of the psychosis type symptoms, and we just need to bump that down. So there's a lot of things that can be adjusted to help with those symptoms. Dementia, like I said, is any kind of underlying severe memory problem puts you at increased risk of having the psychosis. When I see dementia kind of in the early stage, so they have a little bit of movement symptoms, but the cognitive problem is kind of the main overlying issue here in the first year or so, I always keep in mind one of the atypical Parkinsons, like Lewy body dementia, in the differential as a possible diagnosis, because that ends up being a much bigger problem. The psychosis ends up being a much bigger problem than, let's say, a tremor or their walking or slowness. Delirium is a reversible state of psychosis. So when you're ill with some other, medical illness, it can increase your risk of delirium when you've been in the hospital for several days, and you kind of lose that natural sleep-wake cycle that puts you at risk of delirium. And so reversing the underlying issue can remove this state of psychosis as well. So treatment, aside from looking at the underlying risk factors and what can be modified, is usually an antipsychotic medication or a neuroleptic medication, so a class of drugs. There are several of those medications that actually worsen your Parkinson's movement symptoms, so that's important to keep in mind. The ones that don't are what I've listed here. So typically your Seroquel is what, it's also called quetiapine, it's the one with the Q. Is often what your doctor should normally reach for first. Clozaril is a good one as well, although it requires a lot of blood monitoring and labs every several weeks, so it's something that's not as easy to manage. And then Nuplazid, which is one of the medications that we use that's FDA approved specifically for psychosis in Parkinson's disease. Some caregiver tips here to manage psychosis. It's usually not helpful to argue with someone that's having some form of hallucination or delusion. It is, you should try to avoid reasoning. I feel like that works best. Keep calm and be reassuring. Realize that this is real to them. And so by you telling them, nope, that's not, that's not what's going on, and if you start noticing that they get really upset with you and agitated, then a better approach is kind of just recognizing it and distracting away from it, redirecting. And so an example that I put here is, let's say someone's seeing a dog in the room, then you can say, okay, I'll take the dog out, and then go on to whatever else that you guys were doing, and that helps reduce the agitation and it's less argumentative. Here I've just listed some support groups if you guys want to take a picture of it, or if you're familiar with it. There are lots and lots out there. So the Parkinson's Buddy Network is an online community of people impacted by Parkinson's, and it's designed to help make meaningful connections, engage in important dialogue, and there's a lot of really wonderful resources on there. And that's the website just underneath. NeuroTalk is another online Parkinson's disease community. Caring.com is wonderful for caregivers as well as Parkinson's patients. Health Unlocked and Smart Patients with Parkinson's Disease Community for self-care tips. And then Patients Like Me is a very popular online Parkinson's forum. And then I've listed additional resources. You can get a lot of misinformation, as we probably have all realized out there on the internet, and there's things that are written that are just very much instill kind of a fear factor in people. So I like to give my patients options on vetted websites. So Michael J. Fox Foundation has fantastic education resources, the Parkinson's Foundation, Davis Finney Foundation, and then of course DAPS, you guys are familiar. And then if you struggle with anxiety, depression, severe or suicidal thoughts, this is a really important website to go to, which is www.suicidepreventionlifeline.org. And I think I have one more slide. This is also a good one for the National Suicide Prevention Lifeline here, and the phone number. I am happy to take any questions if anyone has any. Can you repeat that? Of hyperness? So feeling really, yes. That is also very common to hear about. It also kind of goes along with anxiety, that feeling of restlessness, like I have to do something, I have to keep moving, I have to keep going. And sometimes when the medication dose gets to its peak effect, and if it's too high in your system, it can also kind of add to that feeling. So yes, that is something that can be addressed as well. Mm-hmm. Yes.
Does Tranzadome fit into the picture anywhere?
Yes, Tranzadome is one of our antidepressants that we use. It wasn't an extensive list that I put up there, but it is one of the antidepressants that are used. It also is helpful for sleep as well. So when I'm selecting one of the medications, I try to think about, okay, what are some other issues that someone's having? So let's say it's depression, insomnia, and we've noticed a lot of weight loss, reduced appetite. Something like mirtazapine is something that I can tell my patient about because it kind of addresses all three at once. So they're different, aside from them just being helpful for anxiety and depression, they also independently can help with other non-motor symptoms that someone's experiencing. So that's always helpful.
Are there any long-term effects of being on Tranzadome for long periods of time?
No, that's why I like antidepressants. They are, very beneficial. There's, no need to kind of, I always, if I'm the one prescribing it, I like to reassess how you're doing. Is it fully managing your symptoms or not? Do we need to go up on the dose? Is it, one thing, for example, with Tranzadome is it can actually lower the blood pressure. And so are we having issues where you're waking up in the middle of the night and you're feeling really dizzy because you stood up and your blood pressure drops? Then maybe that dose is too high for you. Maybe we need to lower it. Maybe we need to switch to something else. So there are side effects to every medication out there. There's side effects, and we always should be reassessing whether or not someone's having any side effects. And sometimes it can happen at any point in time.
Can you back up
I'm sorry?
two slides back?
Oh, 2 slides back, yes. This one?
Yes.
Okay. Any other questions? Yes.
I've noticed there's been a lot of interest in playing solitaire or backgammon, just constantly, even while listening to a seminar or work or phone. Is that something anything, or is that just?
Yeah, so that kind of falls into the obsessive compulsive behaviors. And so there was a slide earlier on in the presentation about loss of serotonin, and that in itself can cause these symptoms of feeling like you're always thinking about and wanting to do a certain action. And sometimes, so that could be due to a loss of serotonin, but other things that it could be a result of is your Parkinson's medication in itself, when the dose is sometimes too high. In my practice, I like to screen for very particular side effects that I know can commonly occur. This usually is a problem of what we call the dopamine agonist class, so pramipexole, Mirapex, ropinirole, Requip. Those groups of medications have a much higher propensity to cause impulse control disorders, is what we call them. And so the most common of impulse control disorders are hypersexuality, so always thinking about sex, and it can greatly impact your marriage, and a lot of people don't like to talk about it because it's a taboo topic, but that could be your medication, and that could be something that's easily addressed. And so that's why it's important to bring that up. So hypersexuality, wanting to spend money excessively, wanting to gamble, wanting to eat excessively. These are the more common ones that you hear, but I've had patients that tell me, for some reason, I get up at 2 o'clock in the morning and I just need to make salsa. And I do it every day. Every time, 2 o'clock in the morning, I wake up and I go to the kitchen and I make salsa and I can't stop. It's very individualized. It's different. So anything that's repetitive and you're constantly thinking about and it's really starting to interfere with your life in some way, that could be what you're dealing with, and that's a great point to bring up. Yeah.
If a person did really want to get some counseling or cognitive behavioral therapy, is
Yeah.
there, I find it overwhelming to try to find someone. Do you
Yes.
have any recommendations at all?
So, that's probably been the case, especially over the pandemic, because therapists are getting therapists, right? And so they're very short-staffed everywhere you go. So, I'm at UT Southwestern, we have a group there, but even there's kind of a backup on, with the wait. And sometimes I send my patients to the psychology department, and there's 3-4 month wait process, just because of how frequently it's requested. And so what I've started doing is I've directed patients to a website called psychologytoday.com. And on that website, sorry, I don't have anything up on here about it, but on that website you can click Find a Therapist, add in your own zip code, and filter for things like your insurance and the type of therapy. I always recommend cognitive behavioral therapy because I think it works for everything. You can filter for the type of therapy, and then it'll give you a whole list of providers in your area, and then you can call them individually and see which one's a good fit for you. Yeah. Any other questions? Right. Okay. Great. So now that you guys have seen my face without the mask, if you ever run into me in the community, please say hello. Trying to now get out there now that we're not in, lockdown, and I can actually start meeting people, so that's wonderful. It's good to see you guys.